Well, today we're here to talk about breast screening recommendations, which have kind of changed over the past couple of years. You might have been confused about them. New tools for improved detection of breast cancer in our community, and why you, the patient, plays the most important role in the healthcare team. So, the first thing we'll talk about is our breast screening guidelines. I think it's really confusing out there when to start your mammograms, when to stop your mammograms, how often to get your mammograms. And as you can see on this chart here, there's a lot of different recommendations. So most of the different governing bodies, like the American College of Radiology and the Society of Breast Imaging, recommend starting at age 40. Unless you have high risk factors, then you need to talk with your doctor first about when to start. American Cancer Society has recently, in the past few years, changed their recommendations to, if you want to start at 40, that's fine, but you really don't have to start until 45. And from 45 to 54, do it once a year, and then from 55 and up, do it twice a year. That's really confusing, isn't it? So the American College of Radiology suggests doing it once a year, starting at age 40, and then having your mammograms until you have a life expectancy of about 5 to 7 years. I have talked with a lot of patients.
Oh, sure.
Yeah. A lot of patients recently have said, oh, my doctor told me I could stop at age 65. Do you plan on living longer than 70? Yes, probably. So as long as you are healthy, and if you know that you would want to do something about a breast cancer if one was found, you should still come and get your mammograms. Okay. So, end the confusion. Let's keep it simple, and let's do what the American College of Radiology says. Yeah. Start at age 40, go until you're no longer going to be living for 5 to 7 years per your doctor. Talk with your doctor about that.
Or if you've got plans.
Yeah. Also, the 3D mammograms, which we are now offering in Grand Rapids, and we'll show you a little bit more about what they look like, they really lower the number of callbacks that we see. So the diagnostic mammograms that you may have been called back for, the ultrasounds, not saying that you won't get called back for those images, but it does reduce the rate of them because the radiologist can see through that breast tissue a lot easier. And remember, breast detection begins with you. You have to make that call to make your appointment to come in and get your mammogram. Or if you have a symptom like a lump or pain, you need to talk to your doctor and have them figure out what's the next step for you.
We recently had a patient who was in her 70s and she hadn't had a mammogram, and her doctor said, go get one more mammogram and then I'll stop bothering you about it. And she got her mammogram and she had breast cancer. So we got it, and she's fine, and it was small, but if she hadn't gone to get that mammogram, it would have been a different story. Mm-hmm. So doctors can just be persistent and persnickety about things.
Thank goodness, huh?
Yes.
Yes. So look around the room. 1 in 8 women will develop breast cancer at some point in their lives. And for our male partners here, 1% of breast cancers are in males. So, and they're usually found later because they don't think it's going to be anything. So they let it go, And once they do come in, it's a little more advanced usually than our female patients. So don't let things go. So the most important thing to remember, as Dr. Owens always says about breast cancer, is most women will not die of breast cancer. And since the 80s, the chance of dying from metastatic breast cancer is down 30%. Does anybody have a guess as to why?
Better detection.
Better detection. People are getting their mammogram.
We're finding breast cancers when they're smaller, and so I can do my job and take the cancer out. But we're also getting better at treating breast cancer, and breast cancer has become, in most cases, not in every case, but in most cases, breast cancer is a chronic disease. It's something that we treat long-term for 10 years with hormone blockers, and then we're always developing new medications that, even if you have an advanced breast cancer, many women are living 10, 15, 20 years with stage 4 breast cancer, which in the past was unheard of. So that's a very good development.
So this month we've rolled out our Do You Know Your Lemons campaign. So it's this family-friendly way of looking for the different signs and symptoms of breast cancer. Now most of these would be found in later stages. A mammogram is usually going to find a breast cancer sooner. So even though knowing you're normal and looking out for any of these symptoms is really important, it's also really important to get your mammograms. But this campaign talks about the different symptoms and also about the different exams that we do for women. So what do you think your 12 signs and symptoms of breast cancer are?
Yep, they're listed there.
It's all listed there.
Open book test.
Yep.
Guys. Open book.
Okay, so up here we have a thick mass, maybe one sign or symptom, or a dimple or indentation would be another one. Nipple crest would be something to look for. Heat or redness. Fluid at an unexpected time coming out of your nipple is a big one to watch for as well. Skin sores that don't heal. Also a bump or a growing vein. A sunken nipple is one that if you haven't had one most of your life and it's a change, it's something to get checked out. A new size or shape between the right and the left side. Orange peel skin, which is skin texture changes. And a hard lump is our final little sign and symptom there.
Like a seed. Not a rubbery lump, but a hard lump.
So what do you do when you have one of these signs and symptoms? So the first part is finding that sign and symptom, and the second step would be to talk with your doctor. And your doctor will set you up with the next step, which is usually a mammogram. In this case, if you have a symptom, it'll be a diagnostic mammogram. And a lot of times with a symptom, you will also have an ultrasound afterwards for the radiologist to take a look both ways. Every now and then, you might have a breast MRI, and then the next step on that is to decide if everything looked normal or if you might need a biopsy, and we'll talk about biopsies in a little bit as well. So then that last picture with the lady with the Band-Aid, she's had her biopsy and she's waiting for her results there. We'll talk about mammograms first. This picture shows the different levels of breast density. So this picture over here, this really white picture, that's an extremely dense breast. So this is probably a younger woman, but if you can imagine finding a white spot or cancer in that breast, it would be like finding a snowball in a snowstorm. It would be really hard.
This is why we don't recommend mammograms on women who are 20. Because dense breast tissue like that, we don't see anything. So younger women with very dense breast tissue, we usually recommend other ways of looking at the breast with an ultrasound or even an MRI. But you can't see anything.
This breast over here is a mostly fatty breast, and as we get older, most of us will tend to have breasts that look like this. Not everybody. Sometimes we get 80-year-olds that are more dense, and sometimes we get 40-year-olds that are more like this, but usually it goes with the trend of getting fattier as we get older and easier to find cancer on. But the reason why we like to recommend 3D mammograms, so a traditional mammogram will take a picture from top to bottom and side to side, and your radiologist is looking at 2 pictures of each breast. The 3D machine is the same machine, but the piece above your head moves in an arc over the breast, and it takes pictures at many angles. So the radiologist goes through many pictures, and they go through your breast tissue in 1 millimeter sections. And in that much detail, they're able to find up to 40% more breast cancers up to 15 months earlier. So it's a fantastic test. And we recommend it for everybody, not just for the ladies with the dense breasts, because it can find things even easier in the fatty breast as well. So this is a picture of a standard mammogram, and we're focusing on this area, which kind of looks like it could just be part of the normal dense breast tissue. But the 3D mammogram picked out that area as a suspicious area for someone to biopsy.
So same breast, same patient, same day, the difference in the pictures.
Yep.
This is helping us a lot.
And we've got another picture here. So this is the traditional mammogram picture. And so the 3D mammogram doesn't look at just 4 pictures, it looks at many, but this is slice 36. This is slice 40. That's the 43rd picture that the radiologist looks at, and it comes into much more focus than it did on this traditional mammogram here. So we're finding things earlier and smaller with the 3D mammograms. And Medicare covers them. Your insurance might not cover it if you're not on Medicare, so we suggest that you call. But most insurances, I'd say at least 75% seem to be covering them now. So what happens if they find something on your mammogram and I give you a call, because that's one of my roles. I call the ladies who've had their screening mammograms and there's something that the radiologist wants to look further at. Most of the time it's a diagnostic mammogram. So don't panic if you get a call from me. 90 out of 100 women will be told that their mammograms are normal. So 10 will be asked to come back for mammograms and or ultrasounds. And of those 10, 6 will be reassured that everything is normal, 2 will be asked to return in 6 months for a follow-up, and 2 will need a biopsy. Now, of the biopsies we do, 80% of them are not cancer. So I know when people hear the word biopsy, their brain goes in a million different directions and they're very worried. But if you can kind of keep that in mind, most of the time it's not cancer. So if you need to come back for an ultrasound, we're looking to see if something that they saw on the mammogram is a fluid-filled cyst like this. It's nice and round and it's dark in the middle, and that's a normal cyst. Cysts can come and go, they can get bigger, they can get smaller, sometimes they can be painful, and we can talk about draining them if they're painful, but this is a normal cyst. Or we look to see if they might have some solid elements to it, like this one. You can see all those little white bits. That's something that we would want to do an ultrasound biopsy on to see what it is. And we don't know what it is based on the picture until we take some pieces out and the pathologist looks at it under the microscope. So we can't tell you that day if it's cancer or not. Sometimes the radiologist will recommend an MRI, and it creates a three-dimensional view of the breast with some contrast. And this has a very large tumor that has some blood flow growing around it. So
this is one of the reasons why we say if you all of a sudden have a new vein that you see on your breast, usually it's nothing. But if it's new and you haven't had your mammogram, then we need to talk about it. You need to get things checked out.
Mm-hmm. So if the radiologist decides you need to have a breast biopsy, I'll be talking with you and we'll tell you what to expect with that. Sometimes they'll recommend a fine needle aspiration for something that looks like a cyst or maybe a complex cyst with a little bit of protein in it. And that is, we just would numb up the skin and drain the fluid out. And we can send that to lab for them to look at. If it's something that we can only see with mammogram, like calcifications, they would recommend a stereotactic or X-ray guided biopsy. And that's done right in the mammogram area. If they can see something with ultrasound, they'll do an ultrasound breast biopsy in the ultrasound area.
That's easier for patients because you get to lay down while they do it?
Yep, and the mammogram one you have to sit really still, and the ultrasound one you can have a little leeway in moving around a little bit. We try to avoid an open surgical biopsy without doing a needle biopsy first, because we want to know what's going on there before we take pieces out to make her job easier.
Well, and 20 years ago when I started doing this, we couldn't do biopsies other than just a needle sucking some cells out. We didn't have stereotactic biopsies where we could get a piece of the tissue. We didn't have ultrasound guided core biopsies where we could get a piece of the tissue and know what it is before we went to the operating room. So it's a huge amount of change over a short period of time in how we diagnose and how we treat breast cancer.
Mm-hmm. And sometimes if the patient has something that you can feel in the armpit, they could do an axillary ultrasound guided biopsy, and that is helpful with treatment planning for people who have already been diagnosed with breast cancer. So how many people do you think in the world are told that they have breast cancer every year? Any guesses? 1.7 million people every year are told that they have breast cancer throughout the world. So it's a big problem. But out of all the people who have cancer in general, 25% of them have breast cancer. So it is by far the most common cancer in women worldwide, and it is increasing more in developing countries where most are found in later stages because they don't have as good of screening programs as we do. This here is a slide about survival rates based on which stage a person is diagnosed with breast cancer. So survival rates depend mostly on what stage the cancer is found. And because it's based on large groups of people, they cannot be used to predict exactly what will happen to an individual patient. So no two patients are exactly alike. Treatment and responses to treatment are different and can vary greatly.
So that slide, many of you maybe who have talked with me, in stage 2 breast cancer, there's a huge spectrum of patients that are included in that. Some who have a tumor that's 2.1 centimeters and some who have a tumor that's 4.9 centimeters. So that spectrum is not, it makes it inaccurate to predict an individual by just looking at 4 stages of cancer. And so we've moved on from stage 0, 1, 2, 3, 4. We still use that a little bit, but we look more at the individual cancer. So every single cancer is different. And right now we can look at the genetics that are in a breast cancer, and that helps us to predict whether that risk is high, medium, or low for that patient. And every year we're finding more parts of that cancer and more genes that we can look at to help us refine that treatment. Because back in the day, everybody who was stage 2 breast cancer, every woman with stage 2 breast cancer got chemotherapy. Now, anybody who's had chemotherapy realizes that this is no fun. And we now know that only about 10% of women with stage 2 breast cancer need to have chemotherapy. They're the ones who benefit from it. So 20 years ago, 90% of the women with stage 2 breast cancer getting chemotherapy had all of the risks of chemotherapy, but they didn't get any benefit from it. So again, we're refining more to treat each individual cancer the best way for that patient.
So what 9 things will increase your risk of breast cancer? We're going to go over this little chart here. The first one is age. So the higher your age, the higher your risk for breast cancer. And that happens because the longer you're exposed to estrogen, the longer you've been exposed to the risk. So unless you know the secret to stop aging, you're at risk. This one here is for periods. Periods increase the estrogen in your body, and the more periods you've had, the more exposure you've had. So things that can reduce your periods are breastfeeding and pregnancy. So risk is lower for women who've had their babies before age 30 and those who have breastfed and breastfed longer. This is because breast cells are copied rapidly during pregnancy. So the older the cells, the greater the chance of mutation. So if your risk is higher if you're over 30 when you've had babies. So it can create more bad copies leading to breast cancer. This one here is for hormone therapy and birth control. So not all hormone therapy and birth control increase your risk for breast cancer, but some can. So you should talk with your doctor about what your medications are and what your breast cancer risk is associated with them. This one is for being overweight over menopause. So your body fat produces estrogen and your risk increases if you're overweight after menopause. This one is for alcohol use and cigarettes. Consuming moderate to increased levels of either one of them may increase your risk for breast cancer. This one here is for a sedentary lifestyle.
I thought it was meditation.
That would make it better, right?
Better. Meditating lowers your risk of breast cancer. I was like, oh, they're meditating. That's so cool. But no.
Yeah.
That's couch potato.
So Dr. Owens tells all of her patients, the best thing that you can do is exercising 30 minutes every day. That's better than any chemotherapy that we can give you in reducing your risk for breast cancer. These little blocks up here, that's for having dense breasts. Having dense breasts raises your risks a little bit of having breast cancer, and it also makes it harder to find the breast cancers. So that's why we talk about doing the 3D mammograms and maybe even talking with your doctor about MRIs. This one here is for lumpy breasts. Now, a lot of us have the lumpy, bumpy breasts, fibrocystic breasts. That's normal. It doesn't increase your risk of breast cancer. But if you have something called atypical hyperplasia, which is only diagnosed through a breast biopsy, that can increase your risk. And so your screening protocols would be different if you had atypical hyperplasia. And that would be something that you would talk to somebody like Dr. Owens about. And then this one here is for mutated breasts. So this one I think can be misleading because 75% of breast cancer patients do not have a family history of breast cancer. I have so many patients who come to me and say, I don't need that 3D mammogram because I don't have any family history of breast cancer, or I don't even need my mammogram for the next 5 years. I'm fine, no big deal. Well, that's not true because you know, anybody can get it. It's not choosy on who it picks. You don't have to have that family history. But there are some people that have a genetic mutation that will have a higher risk of getting breast cancer. So some of these things that may be a warrant to get some genetic testing done would be if you have blood relatives, like a grandmother, mother, sister, aunt, on either side of your family, it doesn't matter if it's maternal or paternal, who've had breast cancer before age 50. Someone who's had both breast cancer and ovarian cancer in the same individual. A relative who has triple negative breast cancer, which is a specific type of breast cancer that affects about 10 to 20% of patients. So how Dr. Owens was talking about, we look at everybody's specific genetics of their cancer. That's part of what we look at. Other cancers in your family in addition to breast, such as prostate, melanoma, pancreatic, stomach, uterine, thyroid, colon, and or a sarcoma. Women in your family with cancer in both breasts, so the same person with cancer in both breasts. Somebody with Ashkenazi Jewish heritage. An African American heritage with breast cancer at age 35 or younger in your family. A man in your family who has had breast cancer really increases your risk. If you have somebody in your family that's tested positive for one of the breast cancer genes, like BRCA1 or 2, or there's CHEK2, PALB2, there's a whole bunch of new ones that they're coming out with. Or if you personally have had radiation to the chest before age 30 because your breasts are still developing.
Which is kind of not something that most people have anymore, but years ago they used to radiate people's chest for acne, or they used to radiate people's chest for a certain immune issues. They would radiate your or for a thymoma, which is a thymus tumor. So in the past, people had radiation to their chest, not so much anymore. Which is why that's brought up, because Dawn's like, why would somebody radiate their chest? Yeah. That's why.
It is important to remember if somebody in your family has tested positive for one of the breast cancer genes, it doesn't mean that you necessarily will. Individual testing is necessary in those cases. And it is also important to remember that having one of these risks for breast cancer doesn't mean that it will necessarily happen to you. Think of it like a raffle. If you have more tickets in the raffle, your chances increase to be selected, but anyone who has even one ticket in the raffle could be chosen. So, all right, guys, who do you think is the most important member of the breast care team? Yourself.
A patient.
Exactly.
Yes.
You have to make the decision to come in for your mammogram or talk to your doctor if you have a symptom such as pain or nipple discharge or a lump. Once that first step is made, the team at Grand Itasca can help you make a plan to get through it. So we have a little cartoon here. If we want to succeed as a team, we need to put aside our own selfish individual interests and start doing things my way.
That would be me.
Never words that have come out of her mouth.
Oh. So Dawn has been a new member for many of you who have met me for something or other. Dawn has been a huge godsend to help manage patients through the spectrum of mammogram, abnormal mammogram, biopsy, office visit with me, surgery, oncology appointments, follow-up appointments. She comes along, she helps to make sure that people's questions are answered, that they're getting the things that they need, and that we don't lose track of what's going on with people. I am not the world's best organized person, and she is awesome at keeping things organized for us. So she is important to the team because she's there for patients, so that's awesome.
So this slide kind of goes over the different steps that a patient will go through, and we kind of like to talk about the team members that you'll meet during these. So when somebody comes for their screening mammogram, they're going to meet the technologist that does the mammogram. If you need a diagnostic mammogram or an ultrasound, I'll be calling you beforehand, and you'll meet not only me and the tech, you'll meet the radiologist as well, and they'll go over some answers that day of what's going on and if further tests are needed. If you do happen to need a biopsy, I'm going to talk you through it. I'm going to let you know what to expect. I'm going to get that appointment scheduled. I'm going to get your follow-up with Dr. Owens, or if you know one of our other surgeons and would like to see them, we get you hooked up with them as well. And I'm there for questions. I want anybody here to know if you're worried about something at home, I'd rather have you call me or Dr. Owens and get answers instead of stressing out about something that's bothering you.
Don't stay home and worry by yourself. Let us worry with you. Okay.
So then the needle biopsy, the people that are in the room are myself and the patient and a technologist and the radiologist. After the biopsy is done and we have results, you see the surgeon. And then if it were to be cancer, you would also then have referrals after surgery to see our oncologist. And he's here in Grand Rapids, and also possibly radiation oncology, which is over in Hibbing, and they do a fantastic job over there too. There's also other places to go that are not Fairview that are sort of close by, but we recommend Fairview because they're great. And other ancillary services that we could use, like if somebody was having a hard time going through chemo, finding things that felt good to eat, we could hook you up with our dietary services, or genetic counselors if somebody was worried about their genetic risks, that kind of thing. Dr. Owens refers a lot of her patients to physical therapy as well if something's bothering them.
Yeah, a lot of times after surgery, women will have a little bit of scar tissue that pulls, or it's a little bit painful, and it's not dangerous, but it's uncomfortable, and physical therapy can work with patients just 1 or 2 visits and then some home exercise things, and things get straightened out very quickly. So we have some really good physical therapists that we work with.
So we're going to talk a little bit about talking with your doctors and coming up with a plan that works for you. I had an aunt. She was my great aunt, and she had this doctor who she told me made her feel like a dumb Polak. I said, well, Auntie Lil, you can go to a different doctor. She goes, no, he would be so mad at me. So I want you to really think about, do you consider your doctor to be an authority figure? Do you follow your doctor's orders? Or do you participate in the shared medical decisions? Do you and your doctor talk about the pros and the cons of the choices that you're going to make and what is best for you? Because that is a big shift in the past 20 years to really be part of the team and be an advocate for yourself. Okay. So how to talk to your doctor. Ask what something means if you don't understand. And even if you leave and still don't understand it and it's running around in your head, call and we can answer that question. Make a list of the important issues to cover and bring the list to your appointment. There are lists if you were to be diagnosed with any kind of cancer. If you go to American Cancer Society, on their website, they have lists of different questions to ask based on the cancer that you have. So that is a good tool to look at as well. Assert yourself. Let your doctor know if you have a concern. Because how are they going to know if something's bothering you if you don't tell them, right? And they can usually find something that works for you. And like I said a couple times, call to get the answers instead of worrying. That's what we're here for. I want to make people feel better about what's going on. All right. So I'm going to let you take over.
Perfect.
Okay.
So if you have a biopsy and things come back and you come to see Dawn and I in the office and we find something like ductal carcinoma in situ or invasive cancer, we spend a lot of time talking about what that means to you, and we talk about what the plan might be to go ahead. As a surgeon, my job is to get rid of the cancer. And so we talk about the options for doing that. So that kind of can depend on how big the tumor is. Most of the tumors that we find are smaller than about 1 inch. Sometimes they're big. That changes our plan. Breast size. If you have a tumor this big in a breast this big, that's a different plan than if you have a tumor this big in a breast this big. So that changes our plan as well. And we talked about individual characteristics of people's cancer. Estrogen receptor status and the HER2 status help us decide. HER2 is a mutation within cancer cells. If that mutation is there, that cancer is more aggressive. And we know that women who have a HER2 mutation actually do better if we treat them with chemotherapy before surgery. Now, this is sometimes a hard sell, because most of the time the reaction is, I have cancer, I want it gone. So we spend a lot of time talking about what that HER2 means is that we can take that cancer out and then do chemotherapy, but it's more likely that the cancer is going to come back that way. So we treat the cancer first, shrink it, and then we take it out, and those patients live longer and do better. So we spend a lot of time talking about that when that's the situation. Luckily, that's not the common kind of cancer. The most common kind of cancer has estrogen receptors and doesn't have a HER2 mutation. It's boring, and it's easy to treat. And I like to tell people they have a boring cancer, okay? If you're gonna get cancer, get a boring one. We check to make sure that there's not any lymph nodes that have cancer in them. Breast cancer spreads through lymph nodes. If there's no cancer in the lymph nodes, the chance that cancer cells have gone elsewhere is between 1% and 2%, okay? That makes survival a lot better. A lot easier to take the breast cancer out and not worry about anything else. But if there's cancer there, we can still work with that. And then patient characteristics and preferences. Some women just say, you know what, I have breast cancer, I want them both off. Just get rid of them. And then we have to talk about that. That's a big surgery, and there's a lot of recovery. So we talk about that. So we have early stage breast cancer, stage 1, stage 2A, and some 2B. And those are constantly changing. But if it's a small cancer that hasn't spread, that's an early stage breast cancer. Locally advanced, big tumor, some lymph nodes that might have cancer cells in them. So some's clinical, some is pathologic. So that means some of it is by what we can feel, and some is what we see under the microscope. Okay. Teamwork opens the possibility of blaming the other. And I would never do that. All right, so mastectomy is still an option, but it's not the only option. Breast conservation therapy is safe. And breast conservation therapy, lumpectomy, and radiation has the same survival, stage for stage, as mastectomy. So if we take out the breast cancer and treat with radiation, or we do a mastectomy, same chance that the patient's going to die from breast cancer. The options, so survival's equivalent, we want to get a cosmetically acceptable breast, and we want low recurrence. So we have to be able to get the edges of the cancer clean. So I want the cancer out, back to normal cells.
A lot of women who are at first thinking, oh, I just want them off, I think that they're not thinking of 5 years down the line when they are a cancer survivor, no longer have cancer, and that's part of your identity, and it's part of your sexuality. So there's a lot of things to mull through when you're thinking of mastectomy versus lumpectomy. And I'd say almost all of our patients are choosing lumpectomy when possible these days.
If it's possible, yeah. Mm-hmm. Yep. And it's not just it's the surgery itself too. With the lumpectomy, it's a day surgery. You come in, we do surgery, you go home, you take a shower the next day, you're moving around within a couple days. It's a quick heal. For a mastectomy, it's a big surgery. You're in the hospital at least overnight, sometimes longer. You have drains that have to be taken care of. The healing is more 3 to 4 weeks. The drains seem to be the most painful part of it. Many women hate their drains, and they might even lie to me to get them out, but I know. And so the healing is much different. And we tend to not have a lot of women over about probably the age of 55 who want to have a mastectomy and reconstruction. That's more common in younger women, but it comes with a whole slew of complications from the surgery. And most of my patients who've had that say that they wouldn't choose to do that again because of the complications. So is breast conservation for me? There's no age limitation. It can happen with invasive ductal or lobular carcinoma. That's no difference. The tumor location is not a problem. Sometimes we have to take the nipple if the cancer is close to the nipple, but that doesn't mean that we have to take the entire breast. Okay? Lymph node status, positive lymph nodes don't mean that we have to take the breast. I have patients who still, well, if you get in there and that lymph node has cancer, are you going to take the whole breast? Nope, because the lymph node has nothing to do with the breast itself. It has to do with telling us whether the cancer has spread. But the cancer in the breast is totally different from that. So, not likely, if there's a lot of disease, more than 1 or 2 or 3 spots, if it's a diffuse, like that MRI that we showed that the whole breast had tumor, if somebody's had radiation before. So if you have breast cancer and have a lumpectomy and radiation and now you have a new breast cancer, we can't do radiation again, so we usually recommend mastectomy in that setting. Pregnancy, a small percentage of cancers are diagnosed in pregnancy. Those women in first and second trimesters do not qualify for lumpectomy because they can't have radiation, because it would injure the baby. And persistently positive margins. You guys may have seen my picture on the billboard or someplace with my friend Kathy, and she's given permission to talk about her. She had a breast cancer that we thought was going to be okay, and we kept taking more and more, and we couldn't get to the edge of her cancer, so she ended up with a mastectomy because it wasn't going to be, we couldn't get to the edge. And then we did. With the mastectomy, we got to the edge. So mastectomy for patients, so availability of radiation. We have radiation, it's in Hibbing, and that's not so far away. There are patients in Wyoming and Montana who have to drive 4 hours for radiation. And so if you have 5 weeks of radiation and you're driving 8 hours a day and you don't have somebody you can stay with, you don't have a way to get back and forth, that's a difficult situation. So many times that availability, especially in places in the United States that are far away from a treatment center, but if you think about it in the third world, in developing countries, radiation is not an issue. So many of those women end up with a mastectomy. A total mastectomy is a removal of the breast tissue, and it can be combined with the sentinel nodes. You can do skin sparing mastectomy, and they can put an implant right back in. And we can actually do a nipple sparing mastectomy now. If the cancer is not close to the nipple, we can leave the nipple intact. And modified radical mastectomy, removal of all the breast tissue and the lymph nodes, and that's not done very often anymore. That's kind of an old school thing that I used to do a lot of 15 years ago, but we don't usually have to do that now. This is what a patient looks like who's had a bilateral mastectomy without reconstruction. Okay. That's a good outcome.
If you do have a reconstruction, they can also tattoo nipples on now, and they make them look very realistic.
Yeah. Mm-hmm. They have a day down at Piper Breast Center where they have the tattoo artists come in, and all they do all day is tattoo nipples. So if somebody thinks they might want to have reconstruction, we have them talk with plastic surgery. They can be done at the same time in a combined procedure, or reconstruction can be done after, up to years after, if somebody decides they want to have reconstruction. Chemotherapy, that's used to treat the possibility of cancer spreading elsewhere. So that we find with the lymph nodes, and it's different medications depending on the patient. There's something here called oncotype testing. That's that individual genetics of your cancer. And I like to tell patients, you get to stay here, but your cancer's going to California. And so we box it up and ship it off to California, and they look to see what your cancer looks like under the microscope. And radiation is to treat the breast or the armpit. So sometimes people who have cancer cells in the lymph nodes of their armpit, if there's a lot of them, rather than taking all those out, we'll treat that with radiation because the complication rate is much lower. And that, again, depends upon specific patient characteristics. Hormone therapy, this is what we talked about. If your cancer has an estrogen receptor, which most breast cancers in women who are postmenopausal do, if we block that estrogen, we can keep that cancer from growing, keep it from coming back, and that can go on for 10 years. Okay? Doesn't make you sick, doesn't make your hair fall out. It's a really good excuse to be crabby. Because it does cause a little bit of mood swings. This is women with breast cancer, man with the flu.
Sorry to the men in the room.
Sorry, boys. So, 1 in 8 women will be diagnosed with breast cancer. Most women with breast cancer don't die from breast cancer. Most breast cancers occur in women with no family history of breast cancer. Screening mammograms, ultrasound, MRI with your doctor or with me. If you know somebody who has questions about that and they're not getting the answers they need, they can always come see me. We'll spend a half an hour, 40 minutes, an hour, whatever we need to come up with a plan for what's the best. Eat healthy, stay active to decrease the risk of breast cancer and other chronic diseases. You know, there's that. Life has given you lemons, so know your lemons, ladies.
And if you have a smartphone, you can get a Know Your Lemons app, and it shows you how to do a breast exam, so you know you're normal, and it goes over different risk factors and stuff like that. And they also have a website. It's fantastic.
All right.